Thank you, dear moderator. Respected expert panel of experts and dear audience, good afternoon. I am with my topic on endobronchial electrocautery, the heat is on. I have no conflict of interest to declare. Actually, I'm getting a bit nervous after two tornado presentation by Professor Saidul Islam and Dr. Kedar Hibari, the two big foods. Yet, it's my great honor to share the same dais with them and talk on a topic which is very close to my heart. And as me and Kedar are talking on heat therapy, so some of our slides may be similar. So I will talk on the ablative therapies, the electrocautery, the principle, technical aspects, pros and cons, how I do it, and why should I do it. As Kedar already have mentioned, the benign and malignant diseases of airway causes airway obstruction and presents with dyspnea, cough, post-obstructive pneumonia, hemoptysis, asphyxia, and if it is bigger enough, it can obstruct the larger airways, may lead to death. And multiple endobronchial modalities exist for management of disorders by using either flexible or rigid bronchoscopy. So what are the ablative therapies? Broadly, the ablative therapies can be divided into two groups, that is the rapid modalities and slow modalities. The rapid modalities includes laser photoresection, electrosurgery, including APC and electrocautery, and mechanical debridement. The slow modalities includes cryotherapy, photodynamic therapy, and brachytherapy. So, what is our choice? The choice depends on the clinical presentation, that is acute presentation or chronic presentation, benign or malignant disease, which types of bronchoscope we have, rigid or flexible bronchoscope, operators training and comfort, availability of equipments, risk-benefit ratio, and of course, the cost. So, what are the indications of electrosurgery? First and foremost, this is the debulking of airway tumors, both benign and malignant lesion, treatment of metaplastic and dysplastic changes, control of hemoptysis, removal of granulation tissue from stent or anastomosis, and release of airway stenosis. And you should keep in mind that there is no role of removal of foreign body, mucus plug, or blood clot by using electrocautery. Use of heat as a therapeutic modality has been practiced for decades. Thermal property of electrical current is used for destroying of tissue and coagulation of bleeding sites. So what is electrocautery by definition? This is an electrosurgical technique that requires probe to tissue contact, whereby the conduction of electrical current ionizes air, resulting in tissue destruction or hemostasis or both. So, electrocautery is a heat ablative therapy. Here, electrical current is used for generation of heat and tissue destruction. Why should we use it? Because it has lower cost, ease of use, and wider availability. Hence, it is called poor man's laser. Looking back in 1930 or more, the first use of electrocautery for the management of tumor was first published by Schaumann in 1913, when he managed and removed an GI malignancy by using of electrocautery. The use of electrocautery for the management of airway obstruction was first published by Guilfoy in 1932, where he removed, debulked a malignant tumor from the lower trachea by use of electrocautery. In 1933, J.D. Kernan used the same method for management of malignant airway obstruction with surgical diathermy. And in 1935, Morse and Boeing reported another case for the management of airway obstruction by electrocautery. Even after getting good results by electrocautery, it was underused in the next half century. Why? For safety concern, cumbersome delivery system, difficulties in grounding, potential risk of electrical shock. In the meantime, there was a rise of laser in 1970s to 1990, there was widespread use of laser for mechanical debulking of airway tumor. So the use of electrocautery was submerged by the use of laser in this time. 50 years after the last case of electrocautery for the management of airway obstruction, in 1985, Hooper and Jackson first reported their paper on 4 cases of malignant airway obstruction by use of electrocautery, where in 3 cases they removed malignant airway tumor, and in 1 cases there was management of hemoptysis. 3 years later, in 1988, they extended their research and they published another paper on 18 patients, where 11 patients were malignant airway lesion and 5 were benign lesion, and the rest was carcinoid. And all the cases, they could be the cases could be managed by use of electrocautery. Meanwhile, in 1986, Gerasim and Shafirovsky published another paper with 14 cases for the management of airway obstruction by use of electrocautery. Meanwhile, a couple of papers were published which focused on the use of electrocautery for the management of airway obstruction. This is a good paper by Shuteja and colleagues, where they managed 14 patients with malignant airway obstruction, and in 11 patients they could relieve airway obstruction in more than 75% relief of airway obstruction. The role of electrocautery for the management of metaplasia or dysplasia was also enlightened by the works of Van Boxem, where they managed 13 patients with electrocautery, and all the patients were radiologically occult lung cancer, and the clinical response was found in 80% cases, where they followed up the patients for 21 months. So these are the positive literatures, and the focus was on the use of electrocautery for the management of airway obstruction. Now let's have some physics. Heat causes tissue coagulation, hemostasis, carbonization, and vaporization depending on the power. The power is the product of electrical current and tissue resistance. The type of tissue is dealing with, the application time, and the contact surface area. So if there is no tissue resistance, current will pass, and there will be no heat production, there will be no effect of electrocautery. So coagulation and hemostasis utilize low voltage, high amperage, and low power setting. And carbonization and vaporization use high voltage, low amperage, and high power setting. Here you see the coagulation effect is found within temperature between 70 to 100 degrees centigrade temperature, and carbonization and vaporization more than 200 degrees centigrade. Depending on the types of works which we have to do, there are 3 modes of electrocautery. These are the cut, coagulation, and blend mode. So what is the cut mode? Cut mode only cuts the tissue without making any hemostasis. Coagulation causes coagulate the tissue, and blend mode both cut and coagulation. So in cut mode, voltage is high enough, which creates an electrical arc, and there is immediate vaporization without giving much time for hemostasis. In blend mode, as I have already mentioned, there is the combined effect of cut and coagulation. And coagulation mode, the heat is around 70 degrees centigrade, and depending on the voltage, there are 3 types of coagulation. That is the soft coagulation, force coagulation, and spray coagulation. In soft coagulation, unmodulated voltage of less than 200 volt is used. There is direct contact of probe to tissue, and there is no arc formation. In force coagulation, there is modular higher voltage, more than 500 volt, and there is an arc between tissue and the probe. And in spray coagulation, the voltage is higher enough, more than 2000 volt, and there is an arc formation. The probe is a bit away from the tissue, and there is spraying and coagulation of the bleeding spot. This is just similar to that of APC, where in APC, the distance between the probe and tissue is several centimeters, and in case of spray coagulation, it is only 1 centimeter. This is the pathological effect of heat on tissue. In animal model, there is the acute effect of heat causes the mucosal ulceration and inflammation up to the depth of perichondrium. Here you see the figure 1, this is the normal cut section of the airway, and in the right hand side, this is the figure after application of heat. There is mucosal ulceration in the right hand side and the perichondrial damage on the left hand side. So in the late effect, there is fibrosis, loss of chondrocyte viability, and ultimately there is extrinsic and intrinsic stenosis. But you should keep in mind that these changes occur when depends on the application time of heat on the tissue. If the application time could be minimized, that is less than 2 seconds, these delayed effects will not occur. So it does not solely depend on the voltage. These are the electrocautery equipments. On the left-hand side, this is the electrosurgery unit, and the right-hand side, this is the grounding pad. And this is the electrocautery accessories, different types of cautery probe, electrocautery knife, and this is the wire snare. And this is on the right-hand side, and extreme right, this is the hot biopsy forceps. So, which type of probe should you use for which purpose? We have solely 3 types of probes: blunt probes, snare, and knife. The blunt probe is used for hemostasis, for surface hemostasis, and for the management of dysplastic changes. It is used in coagulation mode with short electrical burst of for 1 to 2 seconds. Snare is used for both cut and coagulation. Usually, pedunculated tumor with a stalk is cut by using snare, and it is used in blend mode. Knife is used for a large tumor which does not have any stalk, or for the cutting of fibrous tissue. Here, cut mode, coagulation, and blend mode both can be used. And here you see the power setting. This power setting is kept within 40 watt. So how I do it? As Kedar have said, the first is the patient selection. Which patient should we select for doing this electrosurgical techniques? First, the patient, there is no extrinsic compression. There is no extrinsic compression on the airway. The lesion is not big enough so that we can't deal it with flexible bronchoscopy or deal it with application of heat. The tissue, the lung, airway to distal to the obstruction should be viable. So which equipment should be used? This can be done by using both rigid bronchoscopy and flexible bronchoscopy. If the lesion is larger enough, if you are competent with a rigid bronchoscope, this is better to use rigid bronchoscopy. But if you have no feasibility or facility of rigid bronchoscope, or the lesion is small enough, you can use a flexible one. If rigid bronchoscopy is used, the anesthesia is TIVA, that is total intravenous anesthesia with propofol, or under general anesthesia, or for flexible bronchoscopy, it is a conscious sedation. We usually use the monopolar electrical probe. That is, the electrical circuit arc is formed between the probe, the patient, and the grounding pad. Bipolar probe can also be used, but this thing is not suitable for the small hollow viscous like airway. Appropriate grounding is very important. It minimizes the shock. The grounding pad should be kept in hip or to arm, in close proximity to the site where the procedure is done. That is, if we do the procedure near the trachea, so it is better to keep the grounding pad near the arm or near the hip. Okay, insulated ceramic tip bronchoscope should be used so that there is a minimum chance of damage of the bronchoscope probe. One asked about the question of airway firing. Yes, we can minimize the airway firing if we keep the FiO2 below 40%, and always keep the probe away from any combustible material like endotracheal tube. So, what is the safest configuration? Safest configuration is the soft coagulation mode, contact mode, which avoid arc formation and hence ignition. If your machine has auto stop function, this is the best. What is the auto stop function? In auto stop function, machine automatically ends current flow when tissue resistance is raised after a preset level, and it automatically stops firing. Or if the machine does not have any auto stop function, when you see the vapor, you stop pressing the foot pedal. And always try to avoid charring and burning of the tissue. So how I do it? For the management of malignant airway obstruction. In the right-hand side, this is a malignant tumor. This is a hamartoma before and after the procedure. So for dealing with malignant obstruction, we use soft coagulation mode, 40 watt. The tip of the probe is inserted into the mass. If the mass is larger enough, if there is no stock, current is applied with the foot pedal until auto-stop function is activated or vapor is seen. In case of polypoid lesion, wire snare is encircled around the neck of the probe. It is gently closed to the stock. Current is applied and the tumor is released from the base. Then how to remove the tissue? We can remove the tissue by using forceps. By tip of rigid bronchoscopy is used, or by cryo extraction. The process is repeated. Cycle is repeated up to complete clearance of the lesion. In case of bleeding lesion, we can quickly coagulate the tissue or bleeding site by contact mode and spray coagulation. In case of carcinoma in situ, we can use it by blunt probe and soft coagulation mode. For management of benign lesion like fibrous web, that is the post-obstructive airway stenosis or post-tubercular stenosis, we can do this by using cautery knife in cutting mode. Mercedes-Benz incision or radial incision is done to release the stenosis and the dilatation of the stenosed area by applying balloon compression. And this is the bronchoscopic picture. The first A, this is the stenosis, then the radial incision, Mercedes-Benz incision, the C, this is the balloon dilatation, and the last one is after the procedure. Now, a couple of good papers were published on the impact of electrocautery for the management of airway tumor or airway obstructions. Okay. Okay, so this is the largest paper that was published by Momen Wahidi. This retrospective paper was on the management of both benign and malignant airway obstruction, and this study included 94 patients with 117 procedures, both benign and malignant tumors. And in 94% of cases, there was endoscopic improvement, and 71% cases, there was symptomatic improvement of the patients. This is another paper on the airway obstruction by metastatic non-pulmonary malignant tumor. Total 13 patients were included, most from the renal cell carcinoma, and the overall response rate was 85%. This is another paper on comparison of electrocautery and laser therapy, and they showed that the improvement occurred in 70% in either cases. And there are minor complications, hemorrhage that may occur. This is minor hemorrhage. There may be airway perforation, electrical shock, and damage to bronchoscope. We can minimize this by keeping the measures like power below 40 watts, contact time less than 2 seconds, and ceramic tip bronchoscope. Airway fires can be minimized by keeping the FIR to below 40. 2 reports of deaths were there, but it is unclear whether it is due to the procedure or other causes. There are contraindications like patient and tumor factors. The patients which are not suitable for the bronchoscopic procedure or cannot undergo anesthetic procedures, and the patients are oxygen dependent. And the tumor factors, if there is purely extrinsic compression, absence of viable lung beyond the obstruction, and the curative surgery is possible. So this is the pearl. The electrocautery is a rapid heat ablative modality, effective in both palliative and curative settings. Depending on voltage and power setting, there are 3 modes: cut, coagulation, and blend mode. Soft coagulation, contact mode, 40 watt below 2 seconds is the safest configuration. It is a cost-effective procedure with minimum complication. And last but not the least, I wish to buy a BMW, but do I have enough money to buy it or enough money to maintain it? No, but I need a car. This is X-Corolla. I blindly depend on it. This is within my reach. This is durable. This is dependable, have resale value. I have to manage my patients. I have to relieve airway obstruction of my patients. Setting up a laser unit takes more than $200,000. And APC units like $1,000, but setup of an electrocautery unit, only $4,000. So this is your choice, viewers, which you choose. Thank you very much.